Good afternoon and welcome to our virtual journal club session. The topic today is the professional identity formation and in particular how that is framed within our context of CPD. Before we start our topic today, I would like to spend a minute remembering our colleague and friend, dear friend and colleague, Dr. Alex Juricic, who passed away last week, and I know that there will be an outpouring, as it has been, of memories about Alex and thoughts from many of you in our society. But Barbara and I just really wanted to dedicate this session to him as a small part of that. So now let us turn our attention to the topic today, and we have structured it in a way that Barbara Barnes, who needs no introduction really with this group, as you know, she's our leader in the society, in the community, in CPD, talented physician and educator from University of Pittsburgh. And Barbara will be so kind to frame the topic for us and the main issue. I also want to mention that we are very fortunate today to have Dr. Fred Hafferty, the professor of medical education from the Mayo Clinic, who will spend some time with us and share his thoughts on the topic. And as you know, one of the articles we have selected for today's discussion is really Fred's alternative framings of the professional identity formation issue. So with that in mind, I will just start the session and remind you all that we really want you to participate, and you can stop at any point, raise your hand, and I will unmute you, or you can type in a question in the question section, and in that way we can allow you to share your thoughts with us. The concept of this Journal Club is really to provide introductory and framing remarks, as I said, and then to really focus mostly on the discussion and your thoughts and contributions. So thank you very much, and I would like to then ask Barbara to start her points.
Thanks so much, Mila, and again, welcome to everyone. We really appreciate your taking the time this afternoon and look forward to a very stimulating discussion. This concept of professional identity formation has really sort of taken off in the last year, particularly following a lot of articles in academic medicine that really primarily represent initiatives at the undergraduate and graduate medical education levels. But we thought it was really important for us in CPD to really understand some of the literature and then talk about how we can apply this to our field and our day-to-day work. We wanted to start out with just a general definition of professional identity formation. Really talks about the actions, relationships, and activities that we as healthcare professionals engage in over time that really form our attitudes, values, and beliefs within the context of our work. And address issues such as what is our role, what are the attributes of the role, what is important to me, and how do I want others to view me. You can advance to the next slide. Thank you. We've selected 2 articles and also have a video that hopefully all of you have been able to view. The first article was just a recommended article that appeared in Academic Medicine earlier this year that talked about whether it is appropriate to actually look at professional identity as part of Miller's pyramid. And for those of you who may have been at the AAMC meeting in the fall, you might remember that this was a very prominent session at that meeting. There was considerable discussion about really whether this is embedded in all portions of Miller's pyramid or whether it indeed is the highest level that professionals should attempt to achieve. The second article was the one that we are really going to focus on today, which is Dr. Hafferty's very interesting piece that was also in academic medicine, talking about the alternative framings. And the video is archived in case you haven't had a chance to see it. And we are really pleased to have Dr. Hafferty with us today to make some general comments about that article and about the video. So I thought it was really important for us to think about how this relates to continuing professional development. And although in the earlier parts of the continuum there's a lot of focus on identity formation, I think particularly in the emerging healthcare environment, we really need to talk about reforming and transforming professional identity. There's been really a lot less attention given to this, again, as it relates to practicing healthcare professionals. And it's very, very important for us to understand that professional identity is really not static through one's career, and nor it really should not be static along one's career, although I think a lot of healthcare professionals believe that their identity that was formed when they were students and residents is still relevant today. Unfortunately, we are living in a very dynamic healthcare environment, and healthcare professionals are taking on many different roles during their careers. I am mentoring a mid-career faculty member who is still a clinician and an educator, and she was telling me the other day that she finds it very interesting that she's very busy on her days in the clinic, and she's very busy in her days in her administrative work, but somehow she's much more energized when she does her clinical work. And it really made me think about how she is transforming her professional identity, and perhaps, not really understanding the difference in roles and the level of satisfaction that she's getting out of those different roles. It's also important to understand the really dramatic changes in the way we're delivering care. I think it's very difficult, particularly for a lot of physicians, to embrace the idea of truly team-based care, as they were and as I was raised in an environment where we were told that we were the captain of the ship, and that it was our own kind of pyramid where, we as physicians were at the top of the pyramid and everyone else supported us. And I think a lot of the issues that we're dealing with in terms of scope of practice and expansion of licensure really relate to this issue of physicians having a lot of difficulty understanding their role and their identity as part of a team. We also recognize that more and more physicians are being employed by healthcare systems, and I believe this speaks very strongly to a lot of the comments that Dr. Hafferty is going to make, of really changing from autonomous professionals, autonomous in the way we practice, autonomous in the way we made money, to really part of a very bureaucratic organization. And most of us, I think, probably even every day, can really understand the frustration that a lot of physicians and other healthcare professionals have in moving to these employment relationships. In line with that, as we try to standardize care practices, as we're dealing with guidelines and pathways, a lot of professionals feel that this is really taking away their clinical autonomy and really forcing them to just not be very thoughtful about the way they treat individual patients. We're in an increasingly regulated environment with the government and third-party payers, and also are dealing with a lot of pressure on regulation of cost and moving into new payment methodologies. So we see a lot of people who have feelings that they've lost autonomy, that they're not in control, and that they really don't have the same relationships with patients. And I think if we look at this slide and see, how many students today are beginning to form their professional identities with white coat ceremony, looking at probably fairly traditional and altruistic views of what it is to be a physician, and then look around and see the frustration and burnout that is prevalent in many of our colleagues. We realize that the need to constantly reform and transform professional identity is really critical in today's environment. So there are many consequences of these incongruities of professional identity with the realities of the healthcare environment. Next. There's lack of job satisfaction, burnout, and we realize that this is really already starting in residency and then continuing into practice. People become less productive. We have dysfunctional teams, and leading to suboptimal patient care. So this is not just an individual issue. This really has a major impact on the healthcare system and how we are really going to adequately care for patients and populations. So at this point, I'd like to turn it over to Dr. Hafferty and ask him to give some perspective on these issues and really tell us a little bit more about the wonderful research that he's conducted. Dr. Hafferty?
Thank you, Barbara. I appreciate both the invitation to be a part of this discussion and to meet with you, even if it is more electronically based, and basically what I'm looking at is a computer screen. I should tell you before anything else that I come at these topics and issues from the perspective of sociology. I'm a sociologist by training, and that underscores how I think about issues of medical training and medical education, or health, for that matter, health professions training and health professions education. There's been a long-standing interest in issues of training. A framework that's used a lot within medical education is the concept of socialization, with work going back into the 1950s, taking a look at how physicians were educated, are educated as a part of their training. So the focus on professional identity formation is really a contemporary iteration of a framework and framing that goes back some 50 years. The other thing that I point out in general is that the focus over the past 50 years has been primarily, one, on medicine, but then two, on undergraduate medical education, as opposed to graduate medical education, as opposed to continuing professional development. So there's a body of work that you can go out and find on socialization and professional identity formation with respect to undergraduate medical education, a smaller body of work on graduate medical education, but not terribly much yet on continuing professional development, and particularly, as Barbara was pointing out, the emerging interface of a variety of health occupations, not just medicine and nursing, but pharmacy, physical therapy, the whole range of occupations that are beginning to work collaboratively within workplaces and different workplaces, whether they be outpatient settings or inpatient settings. And all of this represents challenges both in terms of practice, but also in terms of educating for practice. And then finally, given my academic background, how to go about best training for the new workplace. And then in terms of our topic, training in terms of professional identity formation. The The other thing that I want to mention, and much more briefly, is it's just my inclination in wanting to try to understand the given issue, like professional identity formation, across different health occupations and how they might collaborate in this process, to look to other places. And because I'm an academic, other literatures. So one of the things that I decided to do was to look within the occupational socialization literature, a place I really hadn't gone much before, and secondly, to look within the military training and socialization literature. And I'll just say in a nutshell that I was struck by the differences among now all three literatures, meaning the one I'm most familiar with, medicine, and then these newer ones, the occupational socialization literature and the military training and socialization literature. Within the occupational socialization literature, there was much more concern with, and I'll use these terms loosely, onboarding and fitting in. How to develop orientation programs, selection programs, recruitment programs, and the like that facilitate bringing new employees into an organization and helping them to feel a part of that organization, adopting the culture of the organization, values, work practices, etc. But it had to do with fitting in. And correspondingly, while certainly the military has a large bureaucratic profile, there was a very different set of concerns within the military training literature about shared identity and its members. Here, there were concerns about the military becoming too bureaucratized and that its members had lost a shared identity. There was concern that the officer corps had accepted the pervasiveness of bureaucratic norms and behaviors as natural and appropriate. And the overarching concern here, and one I found really fascinating, was a recognition that bureaucracies do something really well. And the something that they do really well, better than any other form of organizational practice, is in the routine application of standardized knowledge and skills to standardized problems. Nobody does it better. But the military was concerned with what happens when you have complex problems, what happens when you have unusual problems, what happens when you have non-routine problems. And in that case, standardization they viewed as being insufficient and dysfunctional to complex issues on the battlefield. And so the military became interested in, well, then how do you train officers to, in effect, be resistive to the inappropriate application of routine knowledge and skills to non-routine problems. And that was kind of a light bulb for me, because much of healthcare and the practice of, whether we want to refer to it as medicine or the practice of healthcare, is complex. And there are certainly large sectors of the work that healthcare professionals do that is non-routine. And so the challenge then becomes, well, how do we promote a training environment that not only focuses on issues of teamwork, but focuses on issues of resisting the pressures to, again, apply routine solutions to non-routine problems. And so that then became the sort of launch point for identity formation of professionals and whether the identity formation of professionals was a different kind of identity formation than the identity formation of other participants in the workforce, and whether professionals needed to have a little bit of subversive dialectic in terms of their training and their identity. And I'll stop there.
Thank you, Fred. So if I can advance the slides for you, that would be really good. Why? As you have already heard from both Barbara and Fred, I just wanted to touch on these themes that are really the point of discussion again, and reframe it in these, what seems to me like really tension points. It seems that there are these pairs when we talk about professional identity formation that are in a tag of war a little bit. So on the one hand, there is the need to belong to a team and be part of a profession and that collective, and on the other, the need for us to remain our individuality, and in particular in a profession where the routine problems are becoming less of a daily work, and more is really reserved for mastery of independent thinkers and problem solvers. So part of that is for any profession, as we know, we crave this the need to not only be productive but also have contribute meaningfully to the work and to ultimately really achieve joy from that. And contrast that with what's happening and what we hear more about these days, the burnout and all the negative feelings that are coming off all the pressures that physicians are faced with these days. And so the argument is that we need to now build resilience somehow, and as a positive, as something that would counteract the burnout. And it makes me wonder if that's really what physicians and other clinicians are hearing, or is that just another imposition on asking professionals to really deal with that on their own and develop additional competencies. So as opposed to maybe providing societal assistance for these issues. Again, we're talking about the workplace culture. A lot of this has to do with education and in the workplace, and this is the topic that we continue to explore in our somewhat of a curriculum in the Journal Club, as well as other programming that we have with SACME. But it's really ideal that we have Fred here with us today, because he's the guru of the healing curriculum, and most of you know him because of his work in that realm. So it's that tension again between the professed values that we put on our mission statements and value statements, and then what really is happening in the workplace, and what is really the teamwork, and how is that conceived, and who, what are we trading with, you know, in the context of new clinical teams and what's happening with that. So professional mastery is one of those ultimate goals, really, that everybody would like to achieve. But contrast that with what is really the professional need in terms of physicians understanding, and Fred really talked about this beautifully. It's putting patients first, and what does that really mean as a social contract that physicians subscribe to first and foremost. And how does that really contrast with all the external forces, both regulatory, both quality, even quality metrics, and how that is really affecting their primary social contract with patients and the society. So if that's not enough, the understanding that this is not a static field and that whatever we're doing really is, as professionals, require constant negotiation in the workplace, in the society, with patients, and constant renegotiation of those terms and identities. So this is really to just say that if we are looking at these points and many others that you can think of, then we'd like to open this now for discussion, looking at these questions, and I would like you to maybe start thinking about what are some of the factors that contribute to professional identity formation of any profession. We are primarily focused with physicians in our work, but also nurses and other members of clinical teams. Recently in academic medicine, I think the last issue, there was a topic of research scientists and their professional identity. And what about us? What about the CPD professionals? So what are some of the commonalities that we should be thinking of when we talk about professional identity formation? And then similarly, what is it that we can do in continuing professional development to support physicians' professional identity at crucial points in their professional life? As we already heard, we know that this is not a static field. So what are the contents of CPD, if you wish, on this topic at the beginning of one's career, at the transition point, and maybe at the point of leaving a career? There's very little devoted in education to that end, and it's critically important. And then with any CPD, how do we help physicians and other clinicians assess their professional identity? And how does that inform maybe the content of CPD? I will give you a couple of more questions, and then you can choose which one you would like to discuss and let us know. So finally, what is the role of profession in professional identity formation? So we have professional society like ours. There are many physician professional societies. Many of us represent them. What is the role of the place of work for the society at large? And how is that either complementary or and contributory to this development of professional identity or not? And finally, the question that one of the articles that we've had for review today and the large national discussion brought forward, which is the proposal for amending Miller's pyramid to include above, at the sharp end of the pyramid, so not just have end with doing, but actually being. So is that a desirable or even feasible idea? So at this point, I'd like to turn it over to all of you, and the way to participate is to raise your hand, and I will.
Yeah. And actually, we actually have a couple of questions that have already been submitted. So Kurt Olson asked the question as to whether professional identity is taught or caught. And I wonder, Fred, if you might have any thoughts about that.
Both.
Okay.
No, I just, rather than belabor the question, I simply couldn't vote for an answer that said taught, period. And I couldn't vote for an answer that said caught, period, or picked up. In part because it would send a huge message to learners if medical schools, residency programs, or societies, professional societies, were to make an explicit decision not to address issues of identity. that would send the message that it's not important, which would be an implicit teaching. So I can't see it as either or. Now we could have some interesting discussions about what the optimal balance point is and at what different points in training, et cetera, but it's both. And it can't be other than both, because the absence of one will send messages.
And Kurt, I have unmuted you if you'd like to make some comments.
Thank you. And just to clarify, so the question was more about the question of balance and to what extent it is taught versus caught. And another way of saying that is if you think of education as being a purposeful intervention to change someone in some way, to what extent is identity an educationally sensitive outcome? To what extent is education effective as a primary tool for changing professional identity? Do you have a sense for that?
That's a great topic. Good question, Kurt. And I couldn't help but think that relating this topic more to what we heard from John Parvison last time and more about this less formal development that happens in social circles and is multidirectional and is more of a, so that's one thing. And the other thing that I think of is can we start thinking about supporting professionals with the systems that we're designing, both in the society and in the workplace, in our health, with the health institutions. And I think that would have a lot to do with this. And then if you think about that, what could we do as educators to maybe enable that and to be part of that?
And John, I know that you're on the call. I unmuted you if you'd like to make any comments.
Thanks, Barbara. This is a fascinating topic, and I think we need to hear more about it over the years, because we've heard so much about what I would call the agents of Cochrane, that I think we need a much deeper understanding of what is practice. I made a few notes here, and with regards to Miller doing, but I think the one step beyond doing is reflecting on doing, and there, from the sociological point of view, I think there is an approach to reflecting on practice that is not, you're not just reflecting on the practice, but you're reflecting on the role of the professional in that practice.
Mm-hmm.
And I think that's where professional identity comes in. But the issue of whether it's taught or caught, I think the largest methodology under the rubric of taught is example and role modeling. Mm-hmm. And I believe that is a very important component of acquisition of professional identity. But I also want to mention, I think that it's not just when do you achieve this identity, but when you start to think like a doctor. Mm. And when you start to think not only like a doctor, but one step forward, start to think of yourself as a member of the team. And when you are practicing, part of the reflection and practice is, what would my colleagues in the team think of what I've just done? And so there's a whole area that I think that SACME would be very interesting for SACME members to start thinking about beyond, being just agents of Cochrane.
Right. And Jeannie Jacobs has put an interesting question forward as well. So how do we think at the beginning of the professional, so do we need different students in the training if we pay attention to all these issues, and what is it that we should be paying attention to, and how do we screen the entry point into medicine, for example? And what is that there? I don't know if I got your question right, Ginny.
I unmuted you, Ginny, if you'd like to say something.
Oh, thanks, Barbara and Mila. No, I think you said it. I think I was sad when I saw the slide that described the doctor's lament and saying, you know, medicine is now just a job and not a calling. I don't know if I'd want to think that I'm being cared for someone who just is doing their job, you know, who doesn't have sort of a higher altruistic view of their role. But yet, realistically, are we recruiting the right people to come into the role, or is this a temporary glitch in the scheme of healthcare reform? What would you say to that?
Anyone?
I think
Sure, I'll jump in. This is Fred. The issue of recruiting better, and I'll underline the word better about 6 times, trainees, goes back quite a ways time-wise, and is a frequent response to critical issues that are raised within medical training, health professions training, and the like. We need to do a better job of attracting, recruiting, whatever the verb is, better students, whatever we mean by better. And I have 2 thoughts, and they're not intended to be critical, because I think, Gina, the question is a most important question. But the 2 thoughts are, how robust are our recruitment and decision-making processes around admissions? I think back to my years on the admissions committees at different medical schools, and everybody tries to do a good job. There's a but coming, but the amount of time that we're able to spend on a given applicant, either with the file, during interviews, or during that actual decision-making process, if you will, around the proverbial admissions committee table, is quite limited. And so I've always worried about the ability of recruitment / admission to do the work of finding us the right people. And then the second point, I've totally forgotten in making the first one. So I'll just stop there. I worry about how good a job we can do, and maybe this was the second point, and not to imply that this was a part of the question. Worry a little bit about attention devoted to admissions as a solution, dragging attention away from either formal curricula or other structural aspects of the training process that might be otherwise attended to. And I'll add one more, and I apologize for rambling on. Since we are talking about a lifelong learning process, and since we've explicitly noted that both identity formation and the being and becoming of a good healthcare professional is longitudinal, I can't imagine that even the best of people recruited might, in a toxic environment, and not to imply that all environments are toxic, but in a toxic environment would always remain unscathed or unchanged. And so whatever attention we do pay to the entry point, I'd like to pay maybe a correspondingly greater amount of attention to the training process over the years that it exists.
Barbara, you had something to add, I think.
No, that's okay. I was just, I think we have a lot of questions here, and so I think Betsy Williams raised an interesting point about the applicability of Fred's discussion about the military between the need to be bureaucratic for standard practices and the need to be able to function autonomously in the battlefield. And Betsy, would you like to be more specific about your question or add to that?
I apologize. This is Michael Williams.
Oh, I'm sorry, Michael.
Betsy was kind enough to let me join on her ticket.
Go ahead, Michael.
And we both have been working hard on a BME review on the issue of professionalism. So obviously professional identity formation is of enormous interest to us. But as we're all aware, these frameworks are at best a metaphor for a largely indifferent science. And struggling with this issue was something that a colleague of mine ended up doing at the Naval War College, which ultimately ended in many of the studies and references that were mentioned in passing. The problem in war is that your enemy already knows your doctrine if their espionage is any good. And so they're going to be struggling mightily to make certain that their response foils that doctrine. So if you send your troops in locked to doctrine, they are likely to end up not just professionally failing, but actually failing to breathe. So it's critical that a certain amount of flexibility be built in. However, in a hospital, frequently, if the physician chooses not to follow standard of care, the result is less happy. And in fact, it is arguable that on average, standard is probably better than the average of all changes from standard of care. So the question is, to me, how far to follow this particular metaphor. Now, having said that, the Ericksonian work on professional identity as a thing in itself it's clearly not what I'm trying to challenge. I'm just trying to say, you know, the lead into the discussion was this sort of reference back to the need for independent thought, and so the question is how to bake a system that has reasonable balance between independent thought and the appropriate deference for standard.
That's the tension part.
Yeah.
Right. That's exactly the crux of the issue. That it exists.
Yeah.
Right?
Thank you, Michael. I think that's great, and it would be fun to talk, you know, even at some later point in time about how the notion of reasonable balance might be different within and across different occupations / professions, given the, I'll put the word in quote, the demands of the work environment and the threats inherent in those work environments. I'd love a conversation.
I'd love to have, we would certainly love to have that conversation at an appropriate point, and we have some interesting data that I would love to get your opinion about. I do know that my friend who did this work, and I shouldn't keep him anonymous, his name was George Thibault, and he was chief of strategy at the Naval War College, wrestled with this issue constantly.
Excellent, thank you. We got a comment.
A formidable wrestler.
Right, that's right. We got a comment from Janet Groot about a chapter that she just authored in Cruz's book with Jocelyn Lockyer and Ivan Silver, and specifically talked about the implications for CPD. Janet, would you like to make any comments?
I guess I was thinking, well, it's wonderful to hear everyone's thoughts and different questions. And I guess what we were looking at is like, we didn't even question whether CPD should have a place, but we just thought CPD should have a place for professional identity and career transitions, or just different professional identities. In that, and that's in one of your questions. Like, so it could be the clinician researcher, or what it is to be a female physician versus a male physician, and you know, and it's not always so binary. I know that, but and I wonder, is it premature to talk about what's needed? And so, like we had talked about ballot groups or opportunities for reflective practice or working with mentors and coaches. But it sounds like you're opening up this forum more for like asking the questions, which I'm enjoying listening to.
I think that's great. So that would be the answer in a way to what Kurt started asking, which is what is it education and or reflection of what kind of interventions are really meaningful in this for this topic.
I'll just mention an interesting, we did a workshop on this at SACME, and one of the questions someone came up, pardon me?
At the World Congress you had a workshop, right?
Yes, yeah. And one of the topics that came up is, what about imposter syndrome and professional identity?
Okay.
You know, and are there people who never really consolidate a professional identity? And that's something we're thinking of kind of pursuing, looking at, and knowing that there might be a spectrum of what's been called imposter syndrome.
Mm-hmm.
Would you consider the whole notion of imposter syndrome and its interaction with both burnout and resilience, meaning the more the imposter syndrome, the greater the burnout, or the less the ability to operationalize resilience in the face of burnout? Something like that?
Yeah, that's interesting, to that interaction with it. Yeah, so the person who maybe is more vulnerable to that may burn out more easily. And it sounds like also, like our med students are also talking about burnout. So I would think early on there are those who are already finding it, and maybe it's part of developing their identity. They're burning out because it's also new and so much to take in.
Mm-hmm.
But yeah, I would say there probably is quite an interaction. And then is there a way to measure the professional identity?
Right. And that's actually a very good point. We had a question from Lawrence Liu, who raised that exact issue of really, can we measure professional identity and, you know, or assess it, which becomes particularly important as we do interventions and try to determine if we've really had any impact. Lawrence, would you like to say anything additional about your question? He might be on mute. So Fred, do you know of any literature about how, you know, how we begin to assess or measure professional identity?
Oh, we've quickly jumped, I'm smiling as I'm saying this, we've quickly jumped beyond my comfort zone, meaning into areas of measurement and assessment where I don't dare tread at all. So for me to say no is not to imply that there isn't, but I will say, given the appreciable changes in the workplace And the fact that you can't separate identity formation from, if you will, workplace environment. And by changes in the workplace, I mean just things like the reconfiguration of the workforce itself and who occupies space and place in the contemporary workplace environment, whether it's inpatient or outpatient. So much is changing so quickly. I would be hard-pressed to imagine, but I'm only speculating. Please don't anybody read anything more into this than speculation, that measures of, again, professional identity formation, as opposed to identity formation in general, developed with questions developed 10 years ago, may simply not be appropriate today.
Mm-hmm. And it raises an interesting question about proxy measures. So, you know, if we look at burnout and so forth, maybe there are other ways that we can begin to assess, even if it's, you know, an assumption.
Mm-hmm.
We have a comment, more than a question, from Christine Flores, who says that in her mind, it's less about recruiting better candidates and more about creating systems and environments that support work that energizes people and doesn't suck excitement and joy from their work. I agree with you wholeheartedly. Jeannie Jacobs, as always, is very thoughtful, and Jeannie is beginning to think about the contributions of team-based care and team formation, and in particular physicians as part of those teams, and what does that do to professional identity of physicians, and how is that changing in the current environment, and what are the things we should be paying attention to, both in terms of watching out for and in supporting and providing, in a way, scaffolding them along the way, because we know all of us have examples from our practice where that, whether it's in, you know, surgical teams or in primary care, in larger institutions where, you know, you see this tension of PAs and advanced nurses taking over. There's sense of hostile takeover in a way. And what does that do to the topic we're discussing? Anybody? Raise your hand if you would like to contribute.
I think it's a huge issue in terms of, you know, interprofessional tension. And we here in Pennsylvania, we just have a bill in the legislature for independent practice of nurse practitioners, and it has really created a lot of dissent and a lot of negativity on the part of physicians, and really gotten pretty ugly. And you know, I think as we begin to have you know, some of these discussions, we have a lot of altruistic discussion about, you know, working in teams, but you know, as we start to bridge these lines of practice, I think we're going to have a lot more tension.
Yeah. I think that there are competencies that come to mind that are certainly communication. You know, there are issues around culture of safety institutionally. There are competencies and topics that come from business schools and leadership training, such as, you know, leading change and managing change, that I think are critically important when we talk about these. Kurt Olson, I unmuted you. You raised your hand. Go ahead.
Oh, and I apologize. That my hand was up from before, so.
Okay.
I just took it down.
All right. Anybody else would like to add?
Yeah, this is Fred again. I think this topic is one of the more fascinating and challenging ones that we've talked about, because whatever the particular workplace, hospital, clinic, the like, efforts to create team-based practice are going to be challenged. And it's not impossible, but they're going to be challenged by the, I'm going to call them background or more macro conflicts that exist between and among and within professions/occupations over scope of practice issues. Different groups are going to be going to the legislature each and every year arguing that they should be able to do something. Another group's going to say they shouldn't be able to do something. And all of this forms a backdrop for issues of not just identity, who am I, but also who are they, not me. And I think that individual hospitals or clinics or units within hospitals and clinics can do a great deal to promote team-based activities and a sense of identity as a we and as a team. But those are always going to be challenged, and they need to be recognized as being challenged by these more macro societal level conflicts that are going on as various groups ask for practice-based legislation to exclude or make more restrictive the activities of other groups.
Absolutely. John Parbasing, you raised your hand. Would you like to make a comment?
Thanks, Barbara. Just very quickly, it's to say that we have a lot we can learn from industry as how to introduce teams and the benefits of teams and the creative opportunities that teams allow, which is desperately needed in our healthcare system today. But I think that there's a wonderful report from Google on how to develop teams for the purpose of creativity, and also a number of lessons from industry. John Chambers, I'm thinking of a YouTube video. He's the CEO of Cisco, talking about leading from the middle of the pack. And also the work from Ben Crabtree and Ruben McDaniels and that group, which they were absolutely alarmed at the lack of interactivity and the opportunities for team members to get together. And this was a major issue back in the 90s in industry, where you think of the Ritz-Carlton and other organizations, Toyota for instance, who have made it an absolute necessity to find the time and the space for team members to interact. And I think without that, we're going to see an awful lot of conflict, yes.
Absolutely.
We had another hand raised. I don't know which of the Williams, is Betsy or Michael. Go ahead, I unmuted you.
Thank you, Mila. I apologize. It's me again.
Don't apologize.
In our work, we have found very much like what has just been said before, there is an enormous effect of the organization through its policy structure on the ability to promote interprofessional teams and the ability to create the underlying skills among the physicians who in that structure then become middle management. I might add, you never want to tell them they're middle management because but effectively that is the role that they're providing in that structure. And if the members of the medical cadre have trust in management, it is a whole lot easier to move them forward. The other thing I would add, which is only tangentially connected, if you pick measures like burnout, you need to be rather careful because they're only, at least in our data, sort of a middle range proxy for success in identity, because this trust variable and the other issues with the organization itself also carry a huge amount of the variance in whether the physicians become burnt out.
Right. The joy is better. The joy is much easier to measure, right? Joy of work.
Right.
Right, to be funny.
Yeah, unfortunately, it's not quite like Alex Comfort's joy.
Right, right. So we are.
But I'm probably the only one old enough to remember that reference.
We are getting to the end of our time. I do want to give an opportunity to both Fred and Barbara to give us their final thoughts.
Fred?
My final thought is how grateful I am to everybody for both raising the questions and adding to the discussion. I've come out of all of this understanding and knowing a whole bunch more than I went in, and I owe you all a debt of gratitude. Thank you so much for participating.
This has been a wonderful conversation, and I really appreciate the participation. I personally believe this is a critical issue as we look at workforce and the quality of care that we deliver. I think unless we really try to take a proactive stance on this, we're going to continue to have a lot of dissatisfaction with the work environment and really lose a lot of really talented and gifted people in the profession. Mila?
Thank you. Much like you, I'm very grateful for everybody's time and contributions. I learned a lot, as I always do, from all of you. And much like always, I'm left with questions more than answers. So my question is, if we bring into the mix, so we know how adding teams complicates issues and makes it more complex, what about adding patients as part of that team? And what does that do to the dynamic? So that's my question, and I would like to thank you all again, close this call and our session, and remind you that we will take a bit of a break this summer with the Journal Club, and then we'll try to reconvene again in September. Thank you very much.
Thank you all.
Bye all.
Bye-bye.